I mean, one of the things that I think has come through all that we've heard just in the session, but also earlier, is about making healthier choices easier. And whether we're talking about food or medication or behaviour, the way we live our lives, making healthy choices easier is something that's easy to say, but again, is that something that you feel anyone is taking seriously?
I mean, I think Payal's question was very apt as well, about fostering healthcare citizenship. And perhaps I'll pass the question on to you in terms of those who are making healthy choices easier. That was your phrase, I think.
I think it is happening, so I think it's not impossible. I think it's a lot of this also is interesting if you think about people's social networks. So where we live in San Francisco, there's like such a social culture around health, right? And we get healthy food to our office every week, so it's pretty easy for me to eat really healthy. But that's definitely a very San Francisco thing, and people always talk about that bubble in California. And I know that most places aren't like that. So I think it is possible, but it really has to start. It's really going to take time, and it really has to start. And I think like spread so that these choices are easier, and then also so that they become the social norm. And it's no longer that acceptable for me to eat unhealthy at work because everyone around me is eating really well.
I think I'd put one gloss on the question. I mean, it's what makes healthcare choices valuable to people. And one of the questions which emerges, I suppose, from your analysis of digital health is how, and indeed perhaps a question for our colleague from Vida, if she's still here, is how the deep values and life commitments of individuals are incorporated into the coaching or the therapy which is provided. But digital can tend to be very isolating an individual rather than embedded in, well, we saw this lovely image of the future of Toronto, a love of place and locality. And that's one of the contrasts I think would be worth exploring is how the difference in interrelation between digital prompts and encouragements to take responsibility for health and a love of place and locality and understanding how your healthy choices and your health behaviour shapes your locality. Down to the sort of down to the money side of things, your healthy choices impacting on what's available budgetary-wise for other areas. So the example in this country, I understand, is Devo Mank. It's Manchester, whereas a whole healthcare budget has been devolved from Whitehall to a particular city region. And one of the interesting things I suspect to come out of that will be how people understand their health spending on their individual lives in light of their choices, and that limiting the envelope for what's available for other activities. So I think there's something about ease, but there's something about what you value and your local place and what you can see as being the impact, the consequences of your choice. At the moment in NHS, it's other people's money.
Yeah. And interesting Payal, what you said, essentially about peer pressure, about not wanting to be an outlier. Are there any particular of these questions that Josh posed that people would like to hear discussed? Any strong feelings?
It's connected. You'll understand. It's not exactly that, and you can take it anywhere you want. But I'm also practicing diabetology. When I'm in town, sometimes I see patients, and it used to be that we talked about the patient's compliance. The patient's compliance is, I'm the doctor, and I'm telling you what to do, and you comply with my request. And we went and started using the word adherence, which actually changed. And I'm training in this clinic. It changes the way we approach the patient once we understand. First, bring the patient to believe that you're doing something good, and bring him to adhere the medication. The adherence comes from the patient and not from the doctor. And it's hard to measure success, but it is different for us when we get the patients to adhere to us. I wonder that this adherence issue, is this a way to move to other things that you were talking about?
So I think this is a really interesting space in terms of behavioral medicine. A colleague I work with most at UCL, Rob Horn, is really in this space. And it's the complicating human factors that we've discussed at various points in our conference. Another word in this space, of course, is concordance. That is the unity of hearts, concordance, the coming together of hearts. And that gets to a very interesting space for me, which is not so much perhaps the patient sticking to the agenda, adherence, that the physician has suggested, but rather how the physician and the patient and their relatives, families, come to a common understanding, something a bit deeper at the level of psychology. That is, what matters to the patient in relation to the care of their diabetic condition. That kind of language is also relevant to the shared decision-making language, and I think Gillian Lane was referring to it in sites of scare quotes because it is a very contested language in the UK, just because typically shared decision-making doesn't really mean shared decision-making. It means a doctor still telling the patient what to do, rather than that sense of participation that I think adherence concordance is intended to aim at.
Payal, do you want to come back on that at all? No.
I think that, yeah.
One of the things that we've done in the UK is, and it's been very slow progress, which is a real shame because they've been really significant, something called personal health budgets. And that is where someone who's got a particular condition, has been in receipt of care, is sat down with the relevant care provider or health professional, and the conversation is had about what is important to you in your life, because the average patient getting your HbA1c numbers down is meaningless, but feeling better, having more energy, being able to take the dog for a longer walk, being able to walk to pick up your grandchildren from school, actually personalising the benefits of looking after yourself and making it meaningful is something that personal health budgets have been specifically designed to do. And not only have they shown that outcomes have been better, but costs have been lower as well because of that engagement. And that's a word that I feel we've come to in the UK and in health circles. We're talking about engaging patients, and some go further and talk about activated patients. It feels like you flick a switch with that word, so I'm not so keen myself. But it is difficult to get the semantics right. But certainly that sense of it being a partnership and about it being your life and what matters to you in your life and what you can achieve is absolutely essential for anyone to actually maintain any sort of course of therapy or treatment. Larry, you're waving.
Yeah, there was a comment about Tom Insel and being able to sample your interstitial fluids. So the people here in the audience are, many of them are diabetologists, and that may be one lab value that you need to know frequently, your blood glucose. If you have to play I'm smarter than a normal pancreas and decide your insulin dose. But for most other laboratory values, we talked about being overly attached to looking at devices. So I have patients that there's a very good drug for MS, but it carries a very devastating risk. And there's about a 1% chance of conversion. And I take care of a lot of students who are on this drug, and they only want to run the test once a year, maybe once every 6 months, but I have many of their parents calling up and wanting to run the test weekly. It's a test to see if you're at risk for progressive multifocal leukoencephalopathy. And I don't have a simple answer. Even if the test converts, you're not going to get PML in the next few days. But if we start having, let's say there's a test for a pancreatic cancer mutation that you can get every day. I think I heard somebody looking for subtle changes in jaundice in the conjunctiva. What do we do with if we don't have a definitive therapeutic? You do in diabetes with your insulin, but what if you can't do anything about it? People with Huntington's disease, until they reach childbearing age, many of them didn't want the genetic test to know whether their 50-50 chance was that they are actually going to get it or not. So I think we have to be cognizant that we can't let lab tests run our lives. We have to smell the coffee or whatever, the roses, and not let health concerns dominate normal existence.
Mm-hmm. Yeah, I completely agree. I like that phrase you just used, lab test run lives. Particular concern to me when I was writing a report about 10 years ago when over-the-counter genetic testing was really taking off, and with no sense of the need to educate public about what risk means and how you evaluate it, and the fact that these individual tests and your results for you pretty meaningless outside of looking at the population that you're in. I feel that very strongly again about digital. We have not been educating people about how to use it. It's come so quickly. We talk about culture change being slow. Well, if we think about digital, it's been unbelievably fast. The iPads only came out in 2010. Only 7 years ago, and who can imagine being without a tablet or a laptop or a smartphone now? And that's been a hugely fast change, and I think it's been at such a pace we haven't stopped to think about, okay, how do we actually manage this? And how do we manage the opportunity to have tests that actually might be really confusing and give lots of mixed messages and give us numbers we don't fully understand? I think it's one of those cultural pieces, conversations that we haven't had, that we need to have, and that a group like this should be having.
Just on point on culture change being slow, I suppose Professor Horn's point was slow in the right direction, right? Mm-hmm. So your point about digital was that it's entertainment. It's not about, the title for this session is about the public conscience. Wow, that's about moral psychology, and the challenge is, as you were saying, and the same in a way with personal health budgets, which you referred to, is how innovations in the sort of policy and tech space work with personal moral psychology. So the example in personal health budgets is that people have often felt completely overwhelmed by the responsibility of choosing. They felt abandoned to their own autonomy, essentially. Now, the movement, what you're talking about, is a kind of moral formation movement, and that has happened in personal health budgets. So people have gradually, with support, taken control and felt very authorised to take control when they're supported. So it comes to that question of, in what way are we our neighbours' keepers, and how do those obligations work out as people transition into different kinds of ways of responding to their healthcare needs through whether it's tech or whether it's through personal budgets or whatever. And that's really interesting to me as to how you work with human moral psychology and how we design stuff in which can support people who will typically, it seems, not respond well to when the challenges are very great. Won't get up at 6 a.m. for the morning run.
All right, well, on that note...
So, Thomas Wilkins, I'd like to provoke you a little bit. I believe that people and mankind wants to live very sinful as much as we can, and we tend to cheat on each other and on ourselves as much as we can. So behavioral change is probably a task which is very difficult to surmount. So given the fact that it takes maybe 4 hours a day to have the perfect, optimized, healthy lifestyle, including exercise, doing groceries, doing optimized cooking, etc., if you had an alternative like pharma or nutraceuticals, gives you a cocktail that allows you to do that all what you want to do just for fun, exercise, cook or whatever, but the drug takes away the difficult part, like the diseasing part, would you take that drug?
This was a thought experiment which Thomas posed. What do you think?
Yeah.
I think the simple answer is yes. Yeah.
Do you want to say
so where should we invest? That's the question.
I'm not sure that is the... okay, I think it's a simple answer. So there's a question, isn't there, about what the ethos of a life, of a local community should be. So people who go out running together wouldn't perhaps go running together, but of course they might have caring responsibilities which they can't fulfill as well as caring for their own well-being and diet and exercise. So there's always got upsides, downsides, but the thought experiment presses us to ask, what is morally valuable about taking care of your own health and those of your neighbours? Maybe you've got an answer for this.
Well, the reason why I came up with that, I was recently at a conference in San Diego, and I was invited to the speaker's dinner, had too much alcohol, so I found in the grocery store a hangover drug, right? So I thought, wow, that's cool. I can afford to have the next dinner. But obviously this stuff doesn't work, but it made me think about it was just jumping on it and trying it.
So it's a classic problem of law and license, which, to refer again to Reformation Day, Martin Luther spoke a lot about. That is, what is it which will, what is it that's valuable in life towards which you should order your behaviour, around which obligations cluster, and should we give permission to things which are in some way damaging? That's the question, I suppose, about the hangover cure.
One last quick comment, Leon.
I'd like to comment on the third question that you put up on the board. What qualities should mark a ripe old age? And I'm going to be very personal about this. My ability to come to this conference at the ripe old age that I've reached of 82 is for me a critical issue, that people should be able to continue functioning in things that are important to them. The example that was raised previously of Oxford University forcing people to go out to stop teaching, I think that this is this is not only Oxford, it's in many other places. I think that we are in a problem area, because if they continue, we are stopping younger people coming into those frameworks. And I think that society is going to have to come to grips with the question, as we are an aging society, how are we going to enable people to continue functioning in things that they consider to be important? The consideration of it being important is that it's giving them something and helps them to continue functioning at a high level. And I think that we're not really approaching it. We are using standard decision making. In my country as well, people have to go out and have to stop working at the age of 68. Why at 68? At 68, if you have to stop working, what are you going to do? I see people walking around the hospital where I worked who went out on pension at 68, and I pitify them. I look at them and they are not functioning anymore. And I think that this is a major issue that society as a whole is going to have to take upon itself and ask ourselves, how are we going to help people continue functioning in a valuable manner that is going to improve and continue with their contribution, both to themselves and to society?
I'd just say that I think that's a really important, valid question. Some of the work, again, that we've done in the past has been looking at the importance of work for health, and that doesn't stop in your 60s. There's very strong evidence that having a job, having those expectations of going to work and functioning that way is very positive for your physical and mental health. So if there is no work beyond 60-something, or there are, there are limited